Good evening, everybody. My name is Isabel Germano. I am the chair of the AANS CNS section on tumors, and it is really a pleasure to be here tonight with the president of the Mexican Neurosurgical Society, Dr. Barbara Nettel, with whom we collaborated thanks to the effort of all the people that you see on the panel tonight to prepare a program about brain tumor management. And we want this to be fairly interactive, and we hope that you will enjoy the discussion. Dr. Nettel, I'll hand it over to you.
Thank you very much, Dr. Germano. It is also a pleasure for me to be here in this webinar that we were planning since a long time ago. And I think it's a very important meeting in order that two big associations are working together. Voy a dar unas palabras en español. Bienvenidos todos a este seminario y vamos a estar trabajando en este seminario con la sección de tumores de la AANS y del CNS. Es algo que hemos venido trabajando desde hace varios meses y les damos una cordial bienvenida a esta sesión.
So, Isabel, I think we go into the first part, that is Barbara and Dr. Kate Woodman. So, would you like to present Dr. Sergio or Barbara?
Yes. First, we have the first case. It will be presented by Dr. Sergio Moreno Jimenez, who is the chairman of the Department of Neurosurgery at the National Institute of Neurology and Neurosurgery. And he is a very prominent neurosurgeon in our country, mainly in neuro-oncology and also in radiosurgery. Dr. Sergio Moreno, go ahead with your case.
Thank you very much. And I want to thank Isabel Germano, Barbara Nettel, and Jose Valerio also. I'm going to share my screen for the first case. Can you see it now?
Yes.
Okay. The first case, maybe we will discuss about the tumor resection, about the approach, and also we will discuss something about the neuro-oncology treatment. The first case is a 44-year-old female in 2019. She was operated from a left parasagittal meningioma in 2005 at the MD Anderson Cancer Center, a complete resection. She presented only one postoperative seizure, and she was treated with anti-crisis drugs only for 1 year. And another antecedent, she had in 2007 a second meningioma, left intraorbital meningioma, and she was treated with radiation therapy. The current condition, she started in 2019, 3 months ago, with behavioral changes, some attention problems, also a confusional state, and she also reported a headache of moderate intensity. She was evaluated by a neurosurgeon at the state of Puebla, and he insisted in surgery as a first line of treatment. However, the patient decided to treat her with homeopathic medicine for almost 1 month. The patient returned to us a month later with intracranial hypertension, an altered state of consciousness, and with drowsiness. And I'm going to show you the MRI. This is it was in December 2019. And I'm going to present the MRI. And if you want to make some comments about the patient and the MRI, you can see it's a typical high-grade glioma image. a very huge one, maybe starting at the thalamus, at the right thalamus, the flare and the T2, and the different projections, axial, sagittal, and coronary. I don't know if someone wants to give some comments about the patient, about possibilities of approaches.
Thank you, Dr. Moreno. It's Kate Drummond here. I'm the other moderator for this session. I'm a neurosurgeon from Royal Melbourne Hospital in Melbourne, Australia, and I'm the president of the Asian Australasian Society of Neurological Surgeons. This patient doesn't have any phacomatoses or genetic disorders. It's unusual to have a number of meningiomas and then a high-grade glioma. So there's no background genetic abnormalities.
Yes, this patient wasn't, she's a very difficult patient. She was asked to go to the genetic medical doctor, but we didn't. We don't have that information.
This tumor now obviously is it's an incurable tumor. The differential diagnosis, I think, sits between a glioblastoma or perhaps a diffuse midline glioma. If she's a socially difficult patient, then the conversation will be around whether it's just a biopsy to confirm the diagnosis and best supportive care, or whether she wishes to undergo a resection. And I think you could certainly do that using Glialan. It would be incomplete, but that would be possible, just trying to remove the enhancing and the necrotic part of the tumor to buy some time, given that she's now deteriorating in her level of consciousness, and allow her to go on to adjuvant therapy. But I'd be interested in what Professor Nettle thinks as well.
Yes, of course. And we offered the surgery 1 month ago, the first time we met the patient, and she refused. And 1 month later, because of the altered consciousness, she decided, and also the family decided, to be operated. And that's what we did. And maybe we could discuss something about the approaches.
Mm-hmm. The family, what was the decision of the family?
The second time, she accepted the surgery.
The surgery. Okay.
Yes.
Well, I agree that this is a deep tumor, and maybe you can do a resection, because in order to lower the load of tumor, and the adjuvant treatment could have a better response, you need a less amount of tumor. But since the patient arrived right now with a very low clinical condition, I think maybe she will not be benefit with surgery or resection, because she already has a very low clinical status right now. Maybe try first with some anti-edema therapy before, in order to see if the patient improve her condition, and then try to, if the patient becomes better, you can think about a surgery. Otherwise, I agree with Dr. Drummond that a biopsy will be fine to have a diagnosis, because it will be very difficult to remove a tumor that is already crossing the midline, and
I think
a dislocation.
It would be very reasonable to not treat this patient. I mean, she's already in a lot of trouble. I guess if you were going to offer surgery, I would probably just you could either go interhemispheric or just through the right posterior temporal lobe along the long axis of the tumor. I'd use glial. I think the one good reason to get tissue is if this is a glioblastoma and she's methylated for MGMT, you know, she may have a good response to radiation and chemotherapy, but that would really be the only chance for any sort of prolonged survival. So that's it's a discussion for the patient and the family. I think the likelihood that surgery is going to have a big change on the outcome is low, but not impossible.
Okay. Another comment from the other ones?
Can I chime in? So I'd like to be the devil's advocate and say the primary problem of the patient here is mass effect of a space-occupying lesion with likely blockage of CSF flow from an entrapped temporal horn on the right side. So decompression will definitely help to decrease mass effect and hence may improve neurological status and obtain a tissue diagnosis. Coming in almost like you do a intraventricular tumor from the right side, sort of posterior temporal, posterior inferior parietal, will allow you to go from the long axis of the tumor, and I'd say you can resect 75% of the lesion just to alleviate mass effect. And once you have accomplished that part, the tumor is much more treatable. Whether the patient's long-term outcome will be significantly better is a completely different question. But if you only do a biopsy, this patient is not going to make it through radiation, right? So I personally think you could do either a totally palliative approach, or you can try to do a reasonable resection to just give the patient some space and time to put her affairs in order if it turns out to be a high-grade glioma.
Yeah, I agree.
Thank you very much.
I agree. I think that's right. I retract my decision about a biopsy.
Okay,
I will chime in saying that the arguments in favor and against surgery were very well expressed. But in the way of diagnosis, I would like to also review the DWI images, diffusion weighted images, because one of the differentials here is possibly a primary CNS lymphoma. And so if this tumor restricts on DWI, then perhaps Dr. Drummond's suggestion to do a biopsy is now very valid because we want to differentiate between a GBM and lymphoma.
Okay. And your experience in CNS lymphoma, primary lymphoma, and resection, not biopsy, do you have experience in this?
Well, the pendulum has shifted now, and whereas up until recently, there was really no indication or minimal indication for resection of a primary CNS lymphoma. Now there is, but the fact that this is a posterior butterfly lymphoma, I think is still in the category that perhaps is not a good idea to resect. That being said, the idea of getting tissue diagnosis and differentiating between the two pathologies is because the treatment is different.
Okay. I don't have the diffusion MRI right now, but it wasn't suggestive of lymphoma. Okay, maybe we can go ahead. No, we planned the surgery to enter. The approach was between the post-central sulcus and the interparietal sulcus. This was our approach. I'm going to show some videos. We use a parafascicular approach guided with neuronavigation. You can see there the tumor. We also use the glial for this case, and it was very. I will show here. It was very helpful in this case. No? We can see there the tumor. When we started to take some biopsies, and the transoperative report was a high-grade glioma. So we proceed with the resection. And this was the results. No, a subtotal resection, we can see a small piece of tumor there. It was a post-operative MRI. You can see the left one is the before surgery and the right one after surgery. The patient improved in like 3-4 weeks, and this is the histopathological report. It was a glioblastoma IDH wild type, and she was treated with the STUD protocol. And the interesting thing of this case is that this patient survived almost 3 years, like we can see here. This is this one is the MRI from April of this year, and he presented a new tumor at the same site. So we asked for another MRI for no navigation, and in 3 weeks it increases almost 50% of the size. So we performed also a PET net with methionine, and we performed another surgery, this time with the same approach. This time we didn't use VLM because we don't have it anymore, but we used fluorescein. And it also was very helpful in this case. And this was the postoperative MRI. So the patient has a KPS of 90%. She only has a hemisensitive, left hemisensitive syndrome, but she's very well. And now the question, this is one more time, it was a high-grade glioma, glioblastoma IDH wild type. And the question is the next step. We asked for a foundation one, but maybe we can discuss about the systemic treatment. Could we re-irradiate the patient with radiosurgery, single dose, hypofractionation, re-irradiation with radiation therapy, TT fields, or other. This is interesting because with this kind of tumor, 3 years of survival is, I think, not common.
I think the patient has survived this long because clearly MGMT was methylated. Our next step, I mean, this is going to go very badly now because as it grows, it's going to grow within the thalamus and other very eloquent areas. We would probably just treat with Avastin, with bevacizumab, and leave it that. But you could, of course, use SRS if you wanted to. But I think things are going to go badly now, and the ventricles will get coated with tumor.
Yes, I agree.
I also agree with Dr. Drummond.
Maybe Avastin is a good option, and maybe radiation. I think it's a good combination.
So let me chime in again about radiation, because you mentioned the term radiosurgery, single fraction radiosurgery for the post-operative setting of complex intrinsic gliomas may not be the treatment of choice. You want to hypofractionate this, and you want to divide it up in, let's say, 5 times 5 to the contrast enhancing portion of the recurrent disease pre-resection, that you cover a certain margin. Dr. Mahadevan from NYU has published a bunch of good papers on the topic if you want to look it up. I think that would be my choice, and maybe second-line chemotherapy.
This is a great discussion, and I was asked to be the timekeeper. So I'm going to tell everybody this is fantastic. So let's move on with Professor Cahill.
I was about to chime in, Isabel.
Thank you.
Thank you very much. I hope you guys can all hear me. Let me try to share my screen. Hopefully that is seen, yes?
Yes.
Okay. So this is a very straightforward case, just to try to spark discussion. And I want to start off by thanking Dr. Germano and Dr. Casper, everyone, for the invitation and the ability to present in this forum. So 59-year-old right-handed woman, she's diagnosed with renal cell carcinoma in the last year, just a little over a year ago. She has a recent brain MRI because she has hand weakness, demonstrates a 2.5 centimeter lesion in the left motor cortex, adjacent to the hand motor area. this improves with steroids. What should we do?
Show me the coronals, how close it is to the surface.
So I don't have the coronal image here, I apologize, but it's about a centimeter away from the surface.
So this is a one single metastasis?
Yes, this is a single metastasis in a renal cell carcinoma patient.
So we can make the argument that a gross total resection of the metastasis followed SRS would be the option of treatment.
Mhm.
But what's the systemic disease load, and how many systemic options has the patient been through so far?
That's a good point. So the systemic disease load in this patient is low, and the patient has not had a substantial number of treatments. They just had resection of the primary site and one course of adjuvant therapy.
Yeah, I mean, there's lots of options here, and it depends a little bit on the patient as well. I mean, your options are observation with systemic agents, which sometimes do hold brain metastases, radiosurgery, which I don't know is a great option in renal metastases, or removing it, and you can get as fancy or as pragmatic as you like with that. It's not, I tend to just do these asleep with the shortest distance to the lesion rather than getting too fancy about it. And usually any weakness then does recover because it's cortical, so it recovers. So, I mean, it's a bit of a discussion with the patient and have a look at what adjuvant options are available. But I would favour either continuing observation and look for stability with systemic agent, given that the patient's better with steroids, as long as you can get them off the steroids, as long as they're not on long-term steroids, or I would just remove it, very, very simply without getting too fancy, because in my eyes, doing a lot of fancy monitoring and everything else is only if you're going to stop resection. But in this case, you either take it out or you don't. But interested to hear what the other panelists think.
I think the surgical resection for me is the first option because she has hand weakness by now. And I think with cortical mapping, it could be resected completely. And after that, decide if we should radiate the tumor bed. I think this is the best option.
Let me chime in as well. I like Kate's approach of being bold. So I would actually get bold images, functional MRI scan pre-op, just to show that the motor strip is hopefully displaced anteriorly. Then you come in from posteriorly, shortest distance to the lesion, and do a resection asleep with the DTI. And then you probably have a good chance to resecting this lesion with good recovery. But I would follow up with post-surgical SRS. There's excellent literature that your local control rate improves significantly. Keeping this patient on longer-term steroids to wait for systemic response just carries morbidity with rather little chance for local control. So I think bold here gets you the biggest bang for the buck.
What about pre-resection SRS?
Actually, that has been described. Clinic has been a lot of recent papers about it to try to reduce the leptomeningeal disease and try to do SRS first and then surgical resection. So it's a really interesting data outside, and it's an option. Yeah, but the standard of care of one single metastasis for all this time, based on the literature, is what Casper said. Yeah, resection and SRS. But the new literature make that. What about resection and gamma tile in the surgical bay? If that is an option too?
I mean, increasingly but our being, living where we live, our experience is mostly with melanoma, but we're increasingly doing the SRS before the resection for that reason. And that, I think that's an area where data is accumulating. But I think renal is a little bit of a different disease. I think it's much more encapsulated. So I'm not sure whether that will play out.
Yeah, I just want to comment on that as well, because here at the Ohio State, we're doing SRS before resection of these tumors, almost in all cases, with the exception of a severe large lesions there, like with a lot of edema. So this is a great example, one that here we would treat with SRS first, followed by resection. And I agree with Kate. We would not get too fancy, just get it, take it out. These cases, I think when we leave a little piece behind and then give radiation, they actually suffer much more. There's more edema, there's more issues afterwards. So we'll do SRS followed by resection. We keep it the resection within 7 days after the SRS to avoid edema and problems like that. But I agree with that plan.
I would also like to say that there is a clinical trial that we're participating in, and is run by Dr. Asher at the present time. So hopefully the answer of whether or not this is important to do, and that is the radiosurgery before resection, the answer to that will come in the next few months.
I have one question about the case. Why to radiate the patient before surgery in this case in particular?
So can I comment on this? There's excellent data from Jeffrey Greenspoon, who is a radiation oncologist from McMaster, who showed post-surgical recurrence of a resected metastasis in the access corridor requires an enlarged radiation field for post-surgical adjuvant SRS, which then often has to be fractionated. If you do neoadjuvant SRS pre-resection, you sterilize the field, you get a higher conformality index, which means your field is smaller, your dose is higher, your local control rate goes up. So I very much like Danny's comment on pre-surgical single fraction SRS, especially for renal cell, followed by 7 days later resection.
And I just want to comment there too that when you go and do the resection, even you try to do the one-piece resection to prevent to do piecemeal, yeah? Because when you do piecemeal, when you do the leptomeningeal disease, sometimes it's really hard to take just one single piece, yeah, without causing any damage. So that is the other reason. So I think that sterilized the area has been showing to be effective, but like Dr. Germano said, that there is some clinical data and some studies coming out right now to figure out.
And I think the best results with this approach is when the brain mets is larger than 10 cc's. I think I'm not sure, but I think this is a small metastasis, and I think it can be resected as a block and not piecemeal, as Evalero said. And that's why I have this question. I know it's an option, of course, to give the SRS as neoadjuvant, but also maybe in this case in particular, I would do the other. First, operate the patient and then radiate the bed, and also because it's a renal cell carcinoma.
Dan, do you want to tell us what you did?
Sure. So I did have a question for Dr. Drummond, but I'll do it after I show the results here. So this patient, we considered the expected survival. So the answer to the question was about the KPS, and the number of brain metastases were limited, so the expected survival was good. We actually pursued SRS only in this case. So this is a patient who you can see their frames on here. They had radiosurgery. They actually had a very nice result to SRS alone, which, is variable in renal cell cancer. And we really think about the role of SRS based on the discussion. So the rest of my slides are just based on the discussion that was just had from the group here. So you can see that the boost to the surgical cavity after resection has been shown to be better for local control and better for neurocognition through the Mahajan and the Brown studies that have been published in the last few years. And now with the Stuart Burry's, Tony Escher's study to look at preoperative SRS, I think this is the question to how to minimize the toxicity of whole brain radiation and to maximize the effectiveness of surgery, local control at this site. Thank you.
Good case.
What was your question?
Oh, so you had mentioned your extensive experience with melanoma. So would you approach this lesion differently if it were melanoma? I find that the availability of effective immunotherapy has really changed practice with regards to brain metastasis. Is that something that would affect?
I think both renal and melanoma, systemic agents, depending on the whole view of the patient, their systemic disease load, their performance status, which is kind of hard to get from just one picture, both melanoma and renal, the systemic agents that can provide disease stability has really changed the landscape. Certainly in melanoma, we expect that there may be stability of asymptomatic lesions, and so that has really changed our approach as to how aggressive we are with local treatment, particularly if the patient's got a lot of systemic disease going on. I think that's completely changed the landscape of how we used to think about getting intracranial cure. And you can see sort of stability in 100% of lesions, with 50% responding to some extent. And given the life expectancy of the patient, that may be enough. So yeah, if this was a melanoma and the patient had not been through all of their systemic agents, I would get them off the steroids and try their other options, particularly if you had pathology from elsewhere, so you knew how it was going to respond. I think that would be very reasonable.
Great. Thank you.
So we follow to the second block, Isabel. Okay, so I need to present my boss. Some people doesn't know that it's my boss, but Ed Casper is my boss in Boston, and I'm here in Miami. Ed Casper is neurosurgery oncologist, and myself are gonna be the moderator, and I will present first Dr. Diego Rosito from Mexico. He's a skull-based surgeon, well recognized in Mexico and international. And I have an honor to giving him the opportunity to have that time to talk to us about his case about skull-based tumor. Diego? You're in mute, Diego.
Yes, thank you. Okay. Oh, wait. Just a second. There it is. Okay, first of all, thank you very much for the invitation. It's a great honor to participate in this webinar and to represent also to share with from the Mexican Society, to share our experience and case discussion in this case that I'm gonna share. We are in Mexico City, as I was mentioned, and I'm going to present a case of a 16-year-old female patient that she started 2 months prior to consultation with a cavernous sinus syndrome, that it was mostly like, I would say, rapidly progressive in a way. And she had this MRI that you can see that this is with gadolinium. It doesn't have like a very severe enhancement, but it enhances quietly with, as you can see here, some medialization of the pituitary gland and some important lateralization, involvement of all the lateral compartments and of the different compartments of the cavernous sinus. And as you can see here in the echo, the gradiente, you can see that there's either some hyper, I thought of calcification or hemorrhage inside the tumor, and that was the preoperative treatment. As you can see here in the angio, you can see that there's some important deviation of the mobilization of the carotid, and this is the projection. Okay, the patient with the gadolinium, you can see that it doesn't have like a very important enhancement in these axial cuts, but it does have an important involvement of the oculomotor triangle in these higher parts of the you can see I'm sorry, in these higher parts of the oculomotor triangle. Okay, the patient, as these are the preoperative, the clinic, the syndrome of the cavernous sinus syndrome. And so for me, it was like the question, what is the best approach for cavernous sinus surgery? And I'm here presenting with one of the most renowned skull-based surgeons, Danny. What would you do in this case? It's like, what would you think of how to treat this patient if she has mostly a third nerve palsy? What would you say? What is the best option? In my opinion, my is that this case has a lateralization. It doesn't come either from the pituitary. It doesn't come from. It doesn't seem to be chordoma. You can see that the pituitary is different. It's medialized, and so I would ask the panel what will be the best approach for this specific case.
Very good, Diego. So at this point, my understanding, you don't know what is the diagnosis, right? You just
No.
You see this lesion it enhances less than the pituitary gland, similar to a pituitary tumor, but you're saying it's not a pituitary tumor, correct?
What is the endocrine function of this patient?
She doesn't have any endocrine anomalies. She's okay. She's a young patient. She's quite obese, but no endocrinologic alterations.
Yeah. So I'll tell you what I've done in similar situations, Diego. I can even share, I was not sure what to show in terms of my next case, but I have something similar where that it looks like it could be a meningioma of the cavernous sinus, something in those terms. And what I've done and even published on that, is where we go and perform a decompression of the cavernous sinus, not with a full plan to resect the tumor, but to decompress and to make diagnosis. So in a case like this, one option, and I think that's highly in my list in terms of what I would do here, it's to go endonasal and basically remove all the bone of the mesial aspect, of the medial aspect of the cavernous sinus, and do what Dr. Falbush called he was the first one who published on that with the transphenoidal approach, do a decompression of the cavernous sinus. He published, if I remember correctly, in 2009, a series of 30-some patients. And then once you remove all the bone, you have the opportunity to open the dura or the periosteum near the sella, where you can biopsy there to figure out what it is and confirm, and also near V2, those are safe entrances areas there. Because if it is a meningioma, it's very unlikely you'll be able to resect. But with that approach, by decompressing and making diagnosis, you can confirm if this is a meningioma grade 1, grade 2, or if it's something else. This is interesting. Even Dr. Shaker published on tumors they look like a meningioma of the cavernous sinus, and he has a publication from the late, I think, early 90s, where was amyloidosis. And it looks like amazingly like a meningioma. This is published like more than 20 years ago. And by doing that, he shows that empirically radiation, he votes against it, because that would be another thing. Someone will look at this and just throw radiation. I think a decompression and biopsy is my first option. And of course, if it is something soft and you're there, and it is something else, and you have the opportunity to be more aggressive with the resection as well. So that's what I will probably do here.
So Danny, let me ask you two questions. Coming in nasally, transphenoidally paracellar, you see the ICA is embedded in the middle of the tumor on the left lower panel. How do you make sure that you're not putting yourself at risk, following the tumor and injuring the ICA?
Yeah, it's the main criticism of this technique. I think in the past I presented this at the NASBS, and that was the main criticism people had against being risky to remove that bone in front of the carotid. And I think if it's definitely one risk that you have, but like I said, I'm not planning to go inside heavily and aggressively, but mainly to decompress, remove the bone, and do a biopsy as the first plan to do it. But definitely, I agree. I mean, the carotid is the risk there. I cannot deny that.
Anyone in the panel who would advocate for a right-sided OZ or low frontal-lateral approach and take this out in an open fashion?
I mean, I think that would be my approach, but I agree. This is not a typical lesion. This could be many things, not all of which need to be removed. And so I think the idea of getting a biopsy first or planning for a biopsy first is really important, because you're just not quite sure what it is, and it may not need a surgery.
I agree.
In my experience, I also do transnasal, and sometimes with navigation, we can identify where the vessels are, and you can get a tissue, because tissue is the issue. Yeah, once you have tissue, you know how to treat the patient. And when this become a pituitary tumor, and I resect as more I can, and then I do radiosurgery, the patient resolve the problem. If this is a meningioma, no matter how I do it, orbitozygomatic or transsphenoidal, I don't have success in the cavernous sinus at all. So I still decompress as more I can and followed by SRS.
Right. Diego, tell us what it is.
Yes. Considering the age of the patient, considering that we didn't know what type of lesion this was, it was, according to the radiologist, it was suggestive of a possible meningioma, something that was not a soft, suckable tumor. And considering the age, we decided definitely that we needed to do a surgery. Definitely, there are several types of tumors that we can treat, either an endoscopic, considering the different, very important to consider all the anatomical landmarks, all the anatomical different compartments that can be done. For example, in this case, which I'm not going to detail, but there are some cases like chordoma, pituitary, that the origin is from the midline, you know? And so we can do all these anatomic things in order to have a good decompression when the origin of the tumor is from the midline, you know? For example, in this case. In other cases, for example, transcranial, we have different compartments and different corridors that we can access from the transcranial corridors, different the clinoidal triangles, the oculomotor triangle, the Parkinson's triangle. Those are corridors that we can access, for example, for pathology like this, that is very obvious that in this case, we can have all the decompression and have the view from the trigeminal, the fourth cranial nerve, the third, the carotid, which are very obvious. But in this case, it was very doubtful for me in order to understand what was the origin of the tumor, because I didn't know if it was really a meningioma, if it was, but what I did know is that the oculomotor triangle was a very important part of the clinical part of the patient, since she debuted and she started with a third cranial nerve. So was I going to be able to reach from the endoscopic? I wouldn't be able to have a good decompression of the third cranial nerve from this part. So in my case, we decided to do a transcranial approach. What we do is a regular pterional approach like we are doing here, and having the nice dissection of the anatomy with its official dissection. And at the end, when I'm going to go a little faster here, we are doing it's very important to do an extradural dissection. Here we're doing some of the drilling. I'm going to go a little faster. Let me see, how can I? Very important to identify the orbitomeningeal band, which is an anatomical landmark. Here we can see the superior orbitary fissure. This is the anterior clinoid process. Very important in these cases to go ahead and go faster. I'm sorry for this, just a second. Here, can you see my screen?
We did. Now it's gone.
No, it's gone. Wait a second. Here it is. I'm sorry. There it is. And so we are doing a peeling, and we are doing an extradural clinoidectomy. I'm trying to go faster, but oh, here it is. Okay. And so we're doing the peeling there we are identifying there the middle meningeal artery. I'm going to go a little faster due to time. Here we can identify the anterior clinar process. Very important to do a complete dissection of the cavernous sinus. At this moment, we are identifying there with the rotating dissector the optic canal. The patient, she did have a visual function, so it was very important, even though with a third cranial nerve, but to have a good optic nerve decompression. And so at this moment, we are doing we removed the attachments from the optic roof, from the optic strut, and from the lesser wing. And so at this moment, we are identifying liberating the anterior cranial process. And as you can see, the optic nerve is completely decompressed. I'm going to go a little faster. Then the next step for us, it was very important to decompress and open the falciform ligament in order to have a good decompression. To open at this moment, we are opening the dura, and right now we're going to identify the third cranial nerve down here. And we are opening there the oculomotor membrane from the carotid, from the clinoidal triangle. And there we can see the carotid. Then we continue, we can see completely the carotid. There we can see the third cranial nerve. We are opening the oculomotor cistern. And we are attacking the tumor. We can see that it was quite not as hard as firm as a regular meningioma, and so we could remove part of the tumor, and we could see the carotid there from the oculomotor triangle. Then we open Parkinson's triangle, as we can see here. We can see there the sixth cranial nerve. And then we go ahead again to the oculomotor triangle to continue the removal of the tumor. As we can see, this is the part that I could not have reached from below. And we can see that there we can identify the oculomotor nerve. And this is all the roof of the cavernous sinus, as you can see there. And there we are removing it with the roton dissector from the, and it was not calcification, it was some bled from the tumor. And then we map and identify the complete carotid trajectory. There, it's the third cranial nerve. And then we are removing part of the tumor.
Dr. Rosito, this is fantastic, yes. But we have to move on with the next case. Okay. Perhaps you can tell us what the histology was?
Okay. Did you get a fresh
Yeah, and that was the complete section. I'm going to go to and finally. Okay, this is the immediate post-op MRI. The patient did fine. The pre-op, the post-op, and it was pathology and a typical rhabdoid teratoid tumor. So it was something completely unusual. For me, it was like a different and a typical case where the important thing that I learned from this is that it's very important to dominate either endoscopic and open cases. And it's very important for young neurosurgeons to treat and to learn both techniques in order to apply it to their case. Thank you very much.
Any comments with respect to this, Barbara or Isabel?
I think that this is a rare case. Actually, I was not thinking that it was a meningioma, but congratulations for your presentation, Diego.
Thank you.
Casper, you want to present?
Yeah, so first of all, thank you for your presentation, Diego. I think it was a beautiful case, beautiful technical layout, and shows complementary inside-outside approaches. With having said that, I want to introduce our next speaker, Daniel Providello. He's a good friend of mine. He is professor at Ohio State. He's vice chair of academic affairs there and director of minimal invasive cranial surgery program. He also is active in the AANS tumor section on the executive committee and was recently made chief editor of Neurosurgical Reviews. Danny, you have a lot to offer. Please present your case to us to have a lively discussion.
Is Daniel here?
Maybe he just self-eliminated from the presentation. Give him a minute to log back in.
He just escaped.
While we're waiting, can I ask the question? I don't know enough about atypical rhabdoid tumors. Did that tumor need to be removed in the end? I understand the reason for removing it, but if a biopsy had have been done first, is this a tumor that should have been treated with adjuvant therapy? Oh, there's Danny.
Hey, I'm back. I'm sorry, I don't know what's happening with my internet here.
Okay, Danny. So we were waiting for your presentation, and you, Casper, present you, and we are ready for you. So you want to share your screen?
Good. So I wanted to congratulate the beautiful case that Diego presented. I think that was a phenomenal resection. I want to share this quickly. I think we have just a few minutes. I think this will be an interesting one to see different people's perspective as well. So this is a 45-year-old who presented with some probably unspecific, like some numbness on the body. Then she got better, and because of that unspecific symptom, she got an MRI that showed the imaging that we will show you here. So she initially had this small growth behind the clivus, like related to the posterior clinar dorsum celli. My initial decision was to observe. I said, this is small, but she's 45, young, and in 6 months, she had this major significant growth in a short period of time. Still asymptomatic, no cranial nerves, some headaches, but no other symptom. Definitely a major growth in 6 months there. And this is the side view. So you can see in relation to the pituitary, kind of quite high, it related to the dorsum celli, upper part of the clivus, next to the basilar, medial to the fifth nerve, as you can see in the previous imaging. If I go back here, a little bit of like, you see the fifth nerve right there. So the question here is, I want to hear from you guys. What would you do in this situation?
Patient is asymptomatic.
It's basically asymptomatic. It's incidental finding that now proved to be growing fast in a not easy location. So interesting case.
So this is your base MRI. This is your first MRI.
This is the second now. The first I have in the axial here. This is the first one in the axial, and the same kind of area showing that grew from basically, you see here, from 3 millimeters on the anterior posterior, and it grew 5 millimeters lateral. So in 6 months, and the patient 45.
So if it's growing faster, why would you not be an idea about SRS at this level to try to prevent or stop to continue?
Yeah, I mean, we discussed that with the patient. That's what I want to see what you guys would have done. I don't know if.
So, Danny, you got CSF specimen, spin down, cytology was negative from the CSF, no systemic disease present. It's not.
Nothing else,
Okay.
yeah.
Then you have two options, right? You can go transnasal again, because the big sphenoid will allow you to get to it from the front. Just closing the CSF leak may be a bit of a challenge. Or you can come in with an open approach, and there are a bunch of options how you can get medial to the fifth nerve. If you are technically gifted and willing, you can come in from posterior, or you can come in anterior frontal Kawase type of angle. But it's much bigger morbidity. So if you feel comfortable, a transsphenoidal approach would allow you to come in from where the pathology is and just steal it away from the basilar. So that would be a good approach here.
I know you know me very well, so you know what I did, but I want to see what Diego would have done on this case, Diego.
Yeah, it's a very interesting case, Danny. It's a young patient with a growth tumor. Due to both of those reasons, I would definitely treat the patient. I would consider definitely a surgical approach for this, and definitely it's a very tricky spot because it's just medial to the carotid and lateral to the basilar, and so it's a very tricky spot where you could.
Somewhat posterior to the carotid area.
Yeah, posterior. I mean, posterior medial. I mean, it's posterior to the carotid, but medial to the line from the carotid. In the sagittal, it does seem to have like in the posterior clinoid attachment, posterior clinoid process attachment, and so it would be interesting to do a transposition there of the gland in order to have a nice exposure of the posterior clinoid, which is going to be the attachment mostly of most part of the tumor. That would be the end from the endoscopic point of view, and from the open, it would be like Professor Kasper said, a Kawase approach, but it's very far. It's a bit more medial from the trigeminal nerve, and it's more clival. So perhaps the endoscopic would be a better straightforward.
My experience with the Kawase, it's basically on the most difficult area where usually we end up leaving a little bit of disease when we do the Kawase, because you see very well this ambient cistern here, but everything retroclival, it's not easy. You got to go above and below the fifth nerve, and not easy. So one thing that is not in this picture that I just want to mention, I studied the imaging carefully, and the third nerve, as you can see, emerges from the interpeduncular fossa there, just above the tumor, and the sixth nerve is below. So I felt that, coming endonasal, I could stay below the third and above the sixth nerve. So since we don't have a lot of time, let me just show you. We decided to go endonasal here, I'm going to advance a little bit, but basically a drill out of the clivus and the sella. With an angoscope, I did what we call the interdural transposition, basically just cutting the periosteum and using hemostatic agents to avoid venous bleeding there. This was the 45-degree looking up, drilling the posterior clinoid and bringing the bone. So, because if you leave the bone, you don't have the freedom of movement in the cistern there. So there was this little branch of the dorsal meningeal here, like that runs in that area that I had to dissect from this posterior clinoid, and that allows us to have a good exposure after we took that out. That was probably the most critical part there. You can see the curvature of the carotid that was in this posterior climate. So once we took that out, then we opened the dura below the level of the tumor. I use the Caris a 90-degree, like to cut the dura. It's not like the other approach that we try to put together. So we do the reconstruction more broad. You see the sixth nerve down here, by there? And that's below the tumor. So the tumor is just above there. So I open all the way superiorly, carefully there. So by seeing the sixth nerve was very helpful, because then we see the basilar, follow the basilar superiorly. And on top of the tumor, I basically walk the plane of that basilar up and dissect laterally between the sixth and the third. So this is the lower level of the liliquis membrane there, and the third nerve was just above it, so it was protected above that arachnoid right there. So the third was above, the sixth was below, and then with that, I was able to then reach with a 90-degree instruments behind that carotid and dissected carefully, bringing the tumor in using a 90-degree curette evening, which very rarely I use in the subarachnoid space, but in order to get a good resection laterally there. Then we basically rolled that tumor in, and without touching the sixth and the third nerve, basically operating between the both. So of course, this is it's a small tumor, not a very large tumor, but we were able to get a complete resection by doing those maneuvers. And I use angioscope at the end, make sure there was a complete resection. And this is how we do the reconstruction. We call it soft gasket seal, using the collagen matrix, followed by fat, and then put the nasoseptal flap here, covering it up. And this is the post-op. This patient did very well, was discharged very quickly, but it's interesting, probably because my manipulation and the undersurface of the gland end up with SIADH, had to be readmitted, and we then restricted fluids, they controlled that, and she did well. But she didn't have any CSF leak or anything like that. It was really the issue was having hyponatremia that we had to then control afterwards. But she did great overall, and now has been a couple of years, maybe 3 years out, and no recurrence as well.
And
What
the
was the
histology was a
pathology?
meningioma?
It was a meningioma grade 1. Yeah,
It looked like a meningioma as you were taking it out. It really looked like
no, it
with
was
that
a meningioma,
arachnoid,
and the Ki-67 was a little elevated, but was still grade 1.
Well, let me just congratulate you. Beautiful resection. And I think, once again, a good teaching point to come in where the pathology is. So if the pathology is anterior, it's also helpful to come in from anterior, because you stay away from all the structures you pointed out, and you had perfect tissue planes. You use navigation, I suppose, to get your angles right.
Yeah, always with
Just for
navigation.
people that want to try this.
And monitoring the cranial nerves as well. I always monitor any cranial nerve that is near the lesion. Like a case like Diego presented, also we will do neuromonitoring for the cavernosinus cranial nerves.
Just as a comment for Jose Valerio's initial statement, should we do SRS up front? I think if you don't have tissue, I would really prefer not to do SRS on anything down there, because you don't know what you're radiating, hence your dose may be off, and your local control rate is not ideal with high dose radiation next to a cranial nerve. And then if you have a recurrence, it's much harder to take it out after radiation. So primary resection as the first line approach, I think, was an excellent choice, Danny.
And to also answer Kate's question about Professor Rosito's case, a teratoma does not need to be radiated, right? So starting with SRS in that case would have been an error, because the only cure for that disease is surgical resection. Barbara, I see your hand up.
Yes, I think, or I agree with Dr. Casper, because with the rate growth that this tumor, that Dr. Prevadelo's tumor had, I think the time to take the radiosurgery to do its job, it will be very long, and maybe the patient will, at the moment that the treatment is working, the patient will have a neurological deficit. And I think the best option was surgery. I am not expert in skull-based surgery, but I think any kind of surgery will be better than radiosurgery.
Wonderful. Any other questions from the panel for the presenter? Well, the only thing I'm surprised about is having a grade 1 meningioma with a relatively low Ki-67. How do you explain the growth in 6 months? So you need to really keep a close eye on this patient to make sure there isn't a pocket of higher activity that is, sitting somewhere. So how closely do you follow up with your sequential MRI scans?
Yeah, I did very close. So her Ki-67, if I remember correctly, was around 5%, a little more than usual for a meningioma. So I usually do an MRI in 3 months. The good thing for her, we got a complete resection. So then I do 3, 6 months, 9 months. And for when there's grade 2, and that's a different discussion because most of those we end up giving radiation. But if it is a grade 2 total resection, sometimes we walk it on eggs and don't do radiation and just observe. Those I end up doing more frequently imaging to make sure there's no recurrence. And in her case, I definitely did a little more frequently due to the fact that I was growing fast. But at this point, I think I'm doing every year because it has been 3 years out and no recurrence. And she's intact, by the way, like no cranial nerve deficit.
Excellent, thank you. Barbara and Isabel, maybe some final words?
Yes, I see Professor Jose Valerio Pascua reconnecting, and I think he's going to be back with us. Jose, would you like to give a few closing remarks?
Yes, so I'm sorry that it's raining here in Miami. So, first of all, I want to say thank you to the tumor section and the Mexican Society of Neurosurgery. I think this is the first symposium that we do together, and so we're making history. Yeah, this is good. I think I'm going to say thank you. I think the idea to bring clinical cases and have all this potpourri of knowledge was excellent. I learned a lot. I really appreciate the support from all of you for being here. I think it is something that we need to plan in the future to continue doing it. And from the tumor, for the lecture, what I learned was in interaction lesions, there is a lot of things coming new. Yeah, there's clinical trials. Now we're trying to do SRS before doing resection of tumors. For the GBMs, we have new technology and technique that we can use it. And in a skull-based 360 degrees knowledge of how to treat the skull-based lesion is something new for skull-based training people. Endoscope, skull-based therapy, and regular skull-based techniques has to be a part of the portfolio management that the skull-based surgeon need to have. I cannot say more than thank you to all the panelists, Kate Drummond, Casper, Cahill, Barbara, Diego, Danny. Thank you for everything, and hope that everything looks good. Thank you. And we are.
Muchísimas gracias y a la próxima vez.
Yes, it
Nice
will be not the
Spanish.
first time.
Good.
Muchas gracias.
Thank you all. It was a pleasure to see you. See you soon again on a different venue.
Yes,
Thanks
thank you,
for having me.
everybody.
Thank you all. Thank you all.
Thank you, everyone. Thank you for the invitation.
Thank you.
It was an honor. Thank you.
Thank you, Isabel. Thank you, Barbara.
Thank you, everyone.